Good afternoon, everyone. My name is Dr. Tracy Newman. I'll be moderating today's event. I'm a pediatrician, health officer for the City of Fargo, and medical director at Fargo-Cass Public Health. At NDSU, I am an associate professor of practice in the Department of Public Health and associate director of the Center for Immunization and Research and Education. Today, I have the honor of introducing Commander Jones and Dr. DeCuir, who will together be presenting this webinar titled New Products for Respiratory Syncytial Virus Prevention. Commander Jones is a medical epidemiologist in the United States Public Health Service and the Centers for Disease Control and Prevention, or CDC, working in the Coronavirus and Other Respiratory Virus Division. His current work focuses on the epidemiology, immunity, and natural history associated with SARS-CoV-2 and respiratory syncytial virus. He is co-lead and the advisor of the Advisory Committee on Immunization Practices, Maternal and Pediatric RSV Working Group. He received his medical degree and Master of Public Health from Northwestern University, attended a residency in pediatrics at the University of California, San Diego, and a residency in preventative medicine at CDC. He completed an epidemic intelligence service fellowship while assigned to the Arizona Department of Health Services. His work at CDC has included outbreak response and epidemiologic research on Ebola, Zika, waterborne disease, transfusion and organ transplant associated infections, and respiratory viruses. He has authored or co-authored over 65 scientific manuscripts, and he continues to see patients as a pediatric urgent care physician. Dr. Jennifer DeCuir is a medical officer in the U.S. Public Health Service assigned to the Coronavirus and Other Respiratory Virus Division at CDC, where she supports the IV Surveillance Network. Her current research is focused on COVID-19 and RSV epidemiology and vaccine effectiveness. She joined CDC in 2020 as an Epidemic Intelligence Service Officer in the Division of Global HIV and TB, and subsequently deployed to the CDC COVID-19 response, serving on the Multi-System Inflammatory Syndrome Unit and the Vaccine Task Force. Before joining CDC, Dr. DeCuir completed an MD and a PhD in epidemiology at Columbia University, followed by an internal medicine residency at Johns Hopkins Hospital. This presentation is being recorded and will be available for viewing on the center's YouTube page following the event. For those seeking 1 credit of CE, please follow the link available in the webinar chat to take the pretest. If there's time, Commander Jones and DeCuir will answer questions after the webinar. Please type your questions during the presentation into the Q&A feature of the Zoom platform. If you'd prefer to email them anonymously, please email ndsu.cire@ndsu.edu. Commander Jones and Dr. DeCuir, thank you for joining us today. You can begin.
All right, thanks so much. Please let me know, do the slides look good to go? All right, thank you so much. So today I will be covering the epidemiology of RSV in infants and children, the efficacy and safety of the 2 products that we have to protect infants from RSV disease, nirsevimab and Pfizer's maternal RSV vaccine, and then we'll review recommendations and clinical guidance. So I'll first discuss the initially released guidance that assumes sufficient nirsevimab availability, and I'll then discuss the shortage of nirsevimab and interim guidance for healthcare facilities experiencing limited availability of nirsevimab that was released in a health alert network health advisory. And then I'll lastly discuss some considerations for implementation of these considerations. And then following my talk, I'll pass it off to Dr. DeCuir, who will review the adult RSV vaccines. So first, RSV epidemiology in children. RSV infection is the leading cause of hospitalization in U.S. infants. Most infants are infected in the first year of life, and nearly all by age 2 years. And 2 to 3% of young infants will be hospitalized for RSV. So RSV is a common cause of lower respiratory tract infection in infants, and this is what leads infants to be hospitalized. So the highest RSV hospitalization rates occur in the first months of life, and risk declines with increasing age and early childhood. And although certain medical conditions are associated with increased risk for severe disease, recent studies have shown 79% of children hospitalized with RSV aged less than 2 years had no underlying medical conditions. CDC estimates that each year in the United States, among children younger than 5 years of age, RSV is associated with 1 to 300 deaths, 58 to 80,000 hospitalizations, about 520,000 emergency department visits, and approximately 1.5 million outpatient visits. The new Vaccine Surveillance Network, or MVSN, systematically tests children with acute respiratory illness and tests them for RSV among other pathogens to estimate population-based rates. So displayed are RSV-associated hospitalization rates by age group during 2000 to 2004 in red, 2016 to 2020 in yellow, and during 2021 in gray. So RSV-associated hospitalization rates are highest in young infants aged 0 to 5 months and decrease with increasing age in childhood. RSV-associated hospitalization rates in infants aged 0 to 5 months are more than double those among infants aged 6 to 11 months. And you can see that rates are even lower among toddlers 12 to 23 months and further among children aged 24 to 59 months. And this pattern of seeing the highest rates in infants aged 0 to 5 months is true across different time periods in which MVSN has conducted surveillance. So now we can zoom in and take a closer look at RSV hospitalization rates in children aged 0 to 11 months. So this test demonstrates why passive immunization strategies are pursued for this age group. So the red bars represent MVSN hospitalization rates from 2000 to 2005, and the yellow bars represent 2016 to 2020. The highest rates occur in the first few months of life and peaking at age 1 month, and then decrease with increasing age. So the older an infant is when they get RSV, the less likely they are to be hospitalized for RSV. And this is important when considering which infants benefit the most from passive immunization to protect against severe RSV. The National Respiratory and Enteric Virus Surveillance System, or NERVS, is a system CDC uses to monitor RSV seasonality. And this uses the percent positive RSV tests submitted by over 300 participating labs from across the country. So prior to the COVID-19 pandemic, in most regions of the United States, RSV season started in the fall and peaked in the winter. And this is shown in the gray shaded area. And this has the range of values for the pre-pandemic years during 2009 to 2019. The COVID-19 pandemic influenced RSV seasonality. RSV was mostly absent in 2020. And then as shown in the blue line, there was a summer peak in 2021. And as shown in the black line, there was a slightly early peak in the 2022 to 23 season. And as shown in red, the current RSV season is slightly earlier than pre-pandemic RSV season trends. And importantly, RSV transmission has increased to seasonal epidemic levels in all regions of the United States at this time. And that red line continues to, this is a slightly old slide at this point, but that red line has continued to increase just at a rate slightly earlier than we saw with the 2009 to 19 years. Next, I'll review efficacy and safety of the two products. So as mentioned, there are two products that could protect infants in their first RSV season: a maternal vaccine for the pregnant person from Pfizer, and the brand name is Abrysvo, and a monoclonal antibody, nirsevimab, with the brand name Beyfortus, that's given to the infant after birth. And please note that there is an additional RSV vaccine by GSK, brand name Arexvy, and this vaccine is not approved or recommended for use in pregnant people. And to protect eligible children that are at increased risk in their second RSV season, the only option is nirsevimab. So efficacy for nirsevimab was initially evaluated through 2 multi-country trials that included preterm and term infants. Efficacy was evaluated through 150 days after injection, and the pooled efficacy of the trials was 79% in preventing medically attended RSV lower respiratory tract infection, which I'll refer to as LRTI. And it was 80.6% in preventing RSV LRTI with hospitalization. Nirsevimab had an acceptable safety profile. It was well tolerated in the trials. And the most common reported adverse reactions were injection site reactions and rash, which were present in less than 1% of recipients. In trials, the incidence of serious adverse events was not significantly higher in the nirsevimab group, approximately the same in the nirsevimab and placebo arms. So the efficacy of Pfizer's maternal RSV vaccine was evaluated in a multi-country trial, with the vaccine being administered in the trial at 24 through 36 weeks gestation. And the efficacy was evaluated through 180 days of birth and was 51.3% in preventing medically attended RSV-associated LRTI and 56.8% in preventing hospitalization for RSV-associated LRTI. And these numbers were higher in the 0 to 90 days after birth. Side effects tend to be mild or moderate, temporary for the maternal vaccine, and like those experienced after other vaccinations. The most common local and systemic adverse reactions during trials were pain at the injection site, headache, muscle pain, nausea. There were more preterm births and reports of hypertension during pregnancy, including preeclampsia, that were seen in the vaccine group compared with the placebo group in the clinical trials. But of note that these differences were not statistically significant, so it's not known if this was related to the vaccine or simply due to chance. Related to this, FDA approved and CDC recommendations are through 32 through 36 weeks gestation. And that's because ACIP judged the benefits of maternal RSV pre-F vaccination at 32 through 36 weeks gestation to outweigh any potential risks of the vaccine. So next we'll talk about maternal vaccination recommendations. So the maternal vaccine is recommended for pregnant people during 32 through 36 weeks gestation with seasonal administration. And this means that administering during September through January in most of the continental United States. But in jurisdictions with seasonality that differs from most of the continental United States, being, for example, Alaska and territories and jurisdictions with tropical climates, providers should follow state, local, or territorial guidance on timing of administration. The maternal Pfizer vaccine can be simultaneously administered with other indicated vaccinations. Now, either of the two options, maternal vaccination or use of nirsevimab in the infant, either is recommended to prevent RSV LRTI, but administration of both products is not needed for most infants. So healthcare providers of pregnant people should therefore provide information on both products and consider patient preferences when determining whether to vaccinate the pregnant patient or to not vaccinate and rely on administration of nirsevimab to the infant after birth. Now, I'll later go into more detail on some recommendations for vaccine counseling and including discussing the potential lack of nirsevimab availability during this season as part of this conversation. So now we'll talk about nirsevimab recommendations. So first, I'll go over the initial ones, assuming sufficient 100 milligram doses. So most of the United States RSV season has started, and therefore nirsevimab administration to eligible children should begin as soon as it is available. So nirsevimab should continue to be offered through March to eligible infants and children. And it's mainly important for those born from October 2023 through March 2024. So for infants that are born during this time, October through March 2024, they should be immunized with nirsevimab within 1 week of birth. And the nirsevimab administration can occur during the birth hospitalization or in the outpatient setting. So please immunize infants with prolonged birth hospitalizations shortly before or promptly after discharge, for example, the preterm infants that are in the NICU for some time. So for all other infants that are younger than age 8 months, administer as soon as nirsevimab is available if the infant is younger than 8 months at the time of immunization. Again, this is assuming sufficient nirsevimab availability. Now, because the maternal RSV vaccine was found to be effective, if the mother was vaccinated 14 or more days prior to birth, nirsevimab is not needed for most infants. So there are rare circumstances for which nirsevimab can be considered when the mother has received an RSV vaccine 14 or more days prior to birth, when, per the clinical judgment of the healthcare provider, the potential incremental benefit of nirsevimab administration is warranted. So some examples, and it's not limited to these. So infants born to pregnant people who may not mount an adequate immune response to vaccination or have conditions associated with reduced transplacental antibody transfer. So this could include people with immunocompromising conditions or living with HIV infection. Other examples include infants who might have experienced a loss of maternal antibodies, such as those who've undergone cardiopulmonary bypass or ECMO, and infants with substantial increased risk for severe RSV disease. So this could include hemodynamically significant congenital heart disease, infants who have been admitted to the ICU and are still requiring oxygen at the time of discharge. For at-risk children that are aged 8 through 19 months that are entering their second RSV season, please administer nirsevimab as soon as it is available. If the age at the time of immunization is 8 through 19 months and the child is at increased risk for severe disease for this second RSV season. So the increased risk includes children with chronic lung disease of prematurity who have required medical support anytime during this previous 6 months before the RSV season started, children with cystic fibrosis that have manifestations of either severe lung disease or weight for length less than the 10th percentile, children with severe immunocompromise, and American Indian or Alaska Native children. Now, as mentioned, there's been a limited available of nirsevimab. For the current RSV season, the manufacturer reported a limited supply, particularly for the 100 milligram dose prefilled syringes, and these are used for infants weighing 5 kilograms or more. And so based on manufacturing capacity and the current stock, there are not sufficient 100 milligram doses to protect all eligible infants weighing 5 kilograms or more during this season. And the supply of the 50 milligram doses may also be limited in certain settings. So on October 23rd, CDC released a health advisory describing interim recommendations to provide options for clinicians to protect infants from RSV in the context of this limited supply of nirsevimab. So recommendations for the 50 milligram doses remain unchanged at this time, but to help preserve the 50 milligram doses that are for the most high-risk youngest infants weighing less than 5 kilograms, providers should encourage pregnant people to receive Pfizer's RSV maternal RSV vaccine during 32 through 36 weeks gestation. And the potential for limited nirsevimab availability should be considered when deciding on maternal vaccination or nirsevimab. In healthcare settings with a limited availability of the 100 milligram doses, providers should prioritize infants at the highest risk of severe RSV disease. This includes young infants aged less than 6 months, American Indian or Alaska Native infants aged less than 8 months, infants aged 6 to less than 8 months with conditions that place them at a high risk for severe RSV disease in their first RSV season. So this includes premature birth, less than 29 weeks, chronic lung disease of prematurity, hemodynamically significant congenital heart disease, severe immunocompromise, severe cystic fibrosis, and neuromuscular disease or congenital pulmonary abnormalities that impair the ability to clear secretions. So additionally, 50 milligram doses should be reserved for infants that are weighing less than 5 kilograms, meaning to please avoid using 2 50 milligram doses in place of one 100 milligram syringe for infants that are weighing 5 kilograms or more. And providers should follow AAP recommendations for palivizumab eligible infants, for infants that are less than 8 months, when the appropriate dose of nirsevimab is not available and they're eligible for palivizumab. In healthcare facilities that have limited availability of 100 milligram doses, for palivizumab eligible children aged 8 through 19 months, providers should suspend the use of nirsevimab just for this current season and follow palivizumab recommendations per AAP guidance. Providers should continue offering nirsevimab to American Indian and Alaska Native children aged 8 through 19 months who are not eligible for palivizumab and who live in remote regions where transporting children with severe RSV for escalation of medical care may be challenging, or in communities with known high rates of severe RSV among this age group. And lastly, for my presentation, I'd like to review some considerations for implementation. First, regarding cost and insurance, the maternal RSV vaccine, the list price is $295 per dose. And for insurance, Medicaid should cover the cost without any cost sharing for nearly all full benefit adult beneficiaries with traditional Medicaid. The VFC program is available for persons aged less than 19 years. Most private insurance plans are required to cover the maternal RSV vaccine, but have 1 year to do so. And for nirsevimab, the list price is $495 per dose, and this is for the private sector. Payment flexibilities exist for this season, so providers have 150 days for payment when ordering directly from the manufacturer. Nirsevimab is covered under the Vaccines for Children program, and most private insurance plans are required to cover nirsevimab, but have 1 year to do so. Next, storage, handling, and administration. The maternal RSV vaccine is supplied as a 3-component kit, and it requires reconstitution. So it includes the vial of the lyophilized antigen, a syringe of sterile water diluent, and the vial adapter. So before reconstitution, it should be stored at refrigerated temperatures and not frozen. After reconstitution, it should be stored at room temperature and used within 4 hours. The maternal RSV vaccine is given similar to other vaccines as a intramuscular injection in the deltoid muscle or the thigh, and the dosage is 0.5 milliliters. Nirsevimab is supplied as 2 doses, a 0.5 milliliter or 50 milligram dose in a prefilled syringe, and this has a purple plunger rod, and as a 1 milliliter or 100 milligram prefilled syringe with a light blue plunger rod. Nirsevimab should be stored in refrigerated temperatures, used within 8 hours of removing from the refrigerator. It should not be frozen, shaken, should be protected from light. And nirsevimab is administered similar to traditional active vaccines as a IM intramuscular injection in the vastus lateralis muscle of the anterolateral thigh. And the dose depends on weight. So briefly mentioned before, but for those that are less than 5 kilograms, it's 1 50 milligram dose. And for those in their first RSV season who are 5 kilograms or greater, this is 1 100 milligram dose. So this would be less than 8 months of age. For children at increased risk of severe disease, 8 through 19 months of age, so the second RSV season, 200 milligrams or 2 100 milligram doses are given. The maternal RSV vaccine or nirsevimab can be administered with other recommended vaccines. And some considerations for counseling patients on the RSV vaccine. So either maternal RSV vaccine or infant nirsevimab is recommended for all infants, but administration of both products is not needed, as was mentioned. So when prenatal providers are discussing this with pregnant people to aid in their decision-making, please take into account, for example, the relative advantages and disadvantages of each product, patient preferences, and particularly important this season is whether or not there's local availability of nirsevimab. Prenatal providers who don't offer the maternal RSV vaccine, we ask that you refer patients elsewhere for vaccination. If referring to a pharmacy, please proactively provide a prescription if required by state law for vaccination. So some relative advantages of the maternal RSV vaccine that could be discussed is that it provides protection immediately after birth, and these are when infants are at the highest risk for severe disease. The maternal RSV vaccine might be more resistant to potential mutation. So the RSV protein, the F protein, it doesn't mutate rapidly, but should this happen, the maternal RSV-induced antibodies should be more robust. Some relative disadvantages are that there's potentially reduced protection in some situations, such as pregnant persons who are immunocompromised, the infants born within 14 days. And there are also potential risks, as previously mentioned, for preterm birth and hypertensive disorders of pregnancy, but these are not yet known, yet well established. So potential advantages of nirsevimab include that protection from nirsevimab may wane more slowly compared with the maternal RSV vaccine. Nirsevimab is a direct receipt of antibodies and does not need to rely on transplacental transfer. And then there's no risk for adverse pregnancy outcomes. Some disadvantages include that primarily there are areas with limited availability during this season. Also, nirsevimab requires an injection in the infant. For nirsevimab, please counsel your patients about nirsevimab the same way you would for any other immunization. This includes using a presumptive approach. For example, you'd say, Johnny is due for his nirsevimab dose, as opposed to, what do you want to do about Johnny's nirsevimab dose today? And if your practice does not carry or has insufficient supplies of nirsevimab, it's possible, please refer patients elsewhere in the community where it's available. Please note that as of October 6th, 2023, 2 new CPT codes are available for the administration and counseling for nirsevimab. A vaccine information statement for the maternal RSV vaccine and a immunization information statement for nirsevimab are available. It's also critically important to document receipt of maternal RSV vaccine, as most infants who are vaccinated mothers are not recommended to receive nirsevimab. These conclude immunization information systems, or IIS, electronic health records, or really any written or printed documentation that is going to be needed for the parent to bring to the birth hospitalization or pediatric provider. Some of the IIS rules may depend on state policies or laws for nirsevimab. So in summary, RSV can cause serious illness in infants and children, including hospitalization and death. To prevent and protect eligible infants in their first RSV season, either the maternal vaccine or use of nirsevimab is recommended. An administration of both of these products is not needed, and to protect eligible infants, nirsevimab with age-appropriate vaccines is recommended. The maternal vaccine is recommended for pregnant people during 32 through 36 weeks gestation with seasonal administration, meaning September through January in most of the continental United States, but there are jurisdictions with differing seasonality, and providers should follow state, local, or territorial guidance in these places. Infants younger than age 8 months, born during or entering their first RSV season, are recommended to receive 1 dose. If the mother did not receive an RSV vaccine, the RSV vaccine status is unknown, or if the infant was born within 14 days of maternal RSV vaccination. And finally, nirsevimab is recommended for children aged 8 through 19 months who are at increased risk of severe RSV disease and entering their second RSV season. And I will stop there and now pass it off to Dr. DeCuir.
Okay, thanks very much. So we are going to switch gears and talk about new products for the prevention of RSV in older adults. And I'm going to follow an outline that's pretty similar to what we just heard for infants and children. We'll begin with a discussion of epidemiology of RSV in adults, and then move on to efficacy and safety of older adult RSV vaccination, and then finally talk about recommendations and clinical guidance for use of RSV vaccines in older adults. So starting with epidemiology of RSV in adults. Although RSV is a familiar pathogen to pediatricians and other providers who take care of infants and children, many clinicians are less aware that RSV is also an important cause of respiratory illness in adults. And healthy adults who are infected with RSV often have mild symptoms or no symptoms, but older adults can have an increased risk of becoming seriously ill. And some of the things that older adults may develop with an RSV infection are lower respiratory tract disease like pneumonia, and others could experience exacerbation of an existing serious medical condition like asthma, chronic obstructive pulmonary disease, or heart failure. It's important to note that RSV infection may be mistaken for influenza, COVID-19, or other respiratory illness due to a significant symptom overlap, and there isn't a definitive way to tell whether someone has RSV as opposed to another respiratory illness based on their symptoms alone. Older adults account for most of the burden of severe RSV among the adult population. And among adults aged 65 years and older, RSV has been estimated to cause 900,000 to 1.4 million medical encounters, 60 to 160,000 hospitalizations, and 6 to 10,000 deaths. These incidence estimates can vary widely, and they're affected by infrequent RSV testing in adults and potentially by lower test sensitivity in adults compared to children. Not all adults are at equal risk of severe RSV disease. There are certain chronic medical conditions that have been associated with increased risk of RSV disease, including lung disease like COPD and asthma, cardiovascular disease like heart failure, moderate or severe immunocompromise, diabetes, neurologic or neuromuscular conditions, kidney and liver disorders, hematologic disorders, and also others. And I think it's important to note that the evidence on the clinical risk factors for RSV disease is not as robust as it is for influenza or for pneumococcal disease, which have a longer history of research in the adult population. These are data on chronic medical conditions from CDC's and EIP's RSVNet surveillance network, looking at adults who are hospitalized with laboratory-confirmed RSV infection, again, from RSVNet from the years 2014 to 2018. And according to these data, again, patients hospitalized with RSV, adult patients, almost all of them, 94%, have at least one underlying medical condition, with almost half having 3 or more underlying medical conditions. The most common medical conditions that patients in this sample had were cardiovascular disease, chronic lung disease, and diabetes. It's important to note from these data that these patients are patients who are diagnosed with RSV in the hospital through clinician-directed testing. So it's possible that patients with underlying medical conditions may be more likely to have an RSV test while hospitalized, which could bias these numbers in the upward direction. But these data that we're seeing in terms of the prevalence of underlying medical conditions among patients hospitalized for RSV and the most common medical conditions among those patients is similar to other literature. So overall, the prevalence of comorbid conditions among patients hospitalized with RSV is quite high. In addition to the chronic medical conditions that I was talking about in the last couple of slides, there are a few other factors that are also associated with increased risk of severe RSV disease. And these include residence in a nursing home or other long-term care facility, frailty, which is a geriatric syndrome reflecting vulnerability to poor health outcomes, and finally, advanced age. Let's take a closer look at residence in a long-term care facility. RSV is a frequent cause of respiratory illness in patients in long-term care facilities, and it's well documented as a cause of severe RSV outbreaks. For example, there's one study that showed that 13.5% of all residents in a single long-term care facility had symptomatic PCR-confirmed RSV illness in a single month during an RSV outbreak. RSV in long-term care facilities also contributes a substantial disease burden and cost to the health system. And in an industry-sponsored study using Medicare data, the authors estimated that RSV hospitalizations among long-term care facility residents cost more than $50 million over 6 years, had an average length of stay of 5.3 days, and a cumulative hospital stay of more than 32,000 days. And let's take a closer look at advanced age also. And these are data from RSVNet estimating annual hospitalizations for RSV per 100,000 adults from the 2016-2017 season through the 2019-2020 season. And as you can see, the incidence of RSV hospitalization increases with increasing age. If we break out that age group of 65 plus even more in more detail, we can see that the incidence of RSV hospitalization continues to increase with increasing age, with the highest levels of RSV hospitalization observed among adults aged 75 years and older. And so now let's discuss RSV vaccination in older adults, starting with the efficacy and the safety of the vaccines. There are 2 licensed and recommended vaccines for RSV prevention in older adults. The first vaccine, called RSV, is made by GSK, and the other is Abrysvo, made by Pfizer. Abrysvo is the same vaccine that we just heard about at the same dose that's recommended for use in pregnant people for the prevention of RSV in infants. And I'll reiterate that GSK's RSV is not licensed or recommended in pregnant persons. Both RSV and Abrysvo are recombinant subunit vaccines, and the GSK product is adjuvanted while the Pfizer product is not. There's no preferential recommendation between these 2 vaccine products, so either one can be given when it's available. And now let's talk about some of the data underlying recommendations for these RSV vaccines in older adults. The GSK large phase 3 clinical trial enrolled almost 25,000 participants aged 60 years and older in 17 countries. Importantly, adults with immunocompromise were excluded from the trial. Important because we recognize immunocompromise earlier as an underlying condition that can increase the risk of severe RSV disease. Participants were randomized 1-to-1 to receive either the RSV vaccine or placebo. And these efficacy analyses were based on data after a single dose only, with data collected from May 2021 to March 2023. This timeframe covered 2 RSV seasons for the Northern Hemisphere participants and 1 RSV season for the Southern Hemisphere participants. Over the first RSV season, the efficacy point estimate against the primary outcome, which was symptomatic RSV lower respiratory tract disease, or LRTD, was 82.6%. It declined to 56.1% during the second RSV season after the single dose. And it's important to note that these estimates had wide confidence intervals, as you can see here on the slide, due to a relatively small number of events of the primary outcome during the trial. Efficacy against medically attended RSV LRTD was similar to efficacy against LRTD overall, and it was statistically significant in season 1, but not in season 2. And now moving on to the Pfizer product. The Pfizer phase 3 clinical trial enrolled almost 37,000 older adults in 7 countries. And again, immunocompromised persons were excluded from the trial. Participants were randomized 1-to-1 to receive a single dose of either the RSV vaccine or placebo. And these efficacy analyses were based on data collected from August 2021 to January 2023. which included one complete RSV season for Northern and Southern Hemisphere participants and a partial second RSV season for Northern Hemisphere participants only. Over the first RSV season, the efficacy point estimate against symptomatic RSV LRTD with at least 3 lower respiratory symptoms was 88.9%. And as of an interim analysis, it had declined to 78.6% during the second partial RSV season. Again, these estimates had wide confidence intervals, as we saw for the GSK data, and the efficacy against medically attended RSV LRTD was similar to that against LRTD overall, achieving statistical significance in season 1, but not in season 2. And notably, GSK and Pfizer defined their primary endpoints, the symptomatic LRTD, slightly differently, so we can't directly compare the efficacy estimates from the two trials. So overall, both RSV vaccines demonstrated significant efficacy against symptomatic LRTD caused by RSV among adults aged 60 years and older over at least 2 seasons. However, the trials did have some limitations. They were underpowered to show efficacy in older adult subpopulations at highest risk of severe RSV illness, including adults aged 75 years and older, those who are frail, those who reside in long-term care facilities, and of course, the immunocompromised who were not included in the trials. And in addition to that, the trials were also underpowered to estimate the efficacy against RSV hospitalization, although efficacy against symptomatic illness could indicate efficacy against more severe disease. And from these clinical trial results, despite limitations, it was determined that RSV vaccination has the potential to prevent considerable morbidity from RSV disease in older adults, particularly among those who are at increased risk of severe RSV illness. With regard to safety, overall, both vaccines were generally well tolerated and they had an acceptable safety profile. The most common side effects after both vaccines in the trials were similar to those of other vaccines, and they included pain at the injection site, fatigue, headache, muscle pain, and joint pain. In addition to those common side effects, there were also 6 cases of inflammatory neurologic events, including Guillain-Barré syndrome, observed in the clinical trials, 3 in the GSK clinical trial and 3 in the Pfizer trial. Due to the small number of events, it's unknown at this time whether they occurred by chance or whether RSV vaccination increases the risk of these events. In addition, there is also an imbalance in the number of atrial fibrillation events recorded within 1 month of vaccination in each of the large phase 3 trials, with 10 cases among vaccine recipients compared with 4 cases among placebo recipients in both the GSK trial and in the Pfizer trial. Again, due to the small number of events, it's unclear whether these occurred by chance or whether RSV vaccination increases the risk of atrial fibrillation. Based on these data, RSV vaccination should be prioritized in older adults who are at increased risk of severe RSV disease and therefore most likely to benefit from vaccination. CDC continues to monitor adverse events, including cases of Guillain-Barré syndrome and other inflammatory neurologic events following RSV vaccination through a number of vaccine safety surveillance networks, including VAERS and the Vaccine Safety Data Link. And per FDA post-marketing requirements and commitments, both manufacturers are going to conduct further safety studies, and adverse events after vaccination should be reported to VAERS, even if it's unclear whether the event was related to vaccination or not. And finally, I'm going to move on to the CDC recommendations for RSV vaccination in older adults. Adults aged 60 years and older can receive a single dose of RSV vaccine using shared clinical decision-making. And this recommendation, again, does not specify either of the 2 approved vaccines because there isn't a preferential recommendation for one over the other. So either vaccine can be administered when it's available. So what is shared clinical decision-making? Shared clinical decision-making, which has been used in the past with other ACIP recommendations, means that there's no default decision to vaccinate. And so this is unlike routine and risk-based vaccine recommendations, which by default target all persons in a particular age group or identifiable risk group. By contrast, under shared clinical decision-making, the decision to vaccinate is an individual one, and it's based on a decision process that happens between the patient and the clinician. There are a number of factors that can inform the shared clinical decision-making process, and we've listed a few of them here. So things to consider are the best available evidence of who might benefit from vaccination, an individual patient's characteristics, their values and their preferences, the healthcare provider's clinical opinion, and the characteristics of the vaccine. Which considerations go into shared clinical decision-making can vary from one vaccine to another. And in the bottom right of this slide, there is a link to the ACIP general webpage about shared clinical decision-making, if you'd like to learn more. Now, speaking specifically with regard to RSV vaccination and shared clinical decision-making, the most important thing to think about for clinicians and for patients is the patient's risk of severe RSV disease. And as we saw, the benefits of vaccination are most likely to outweigh the potential risks in older adults who are at increased risk of severe RSV disease. So this is the slide that we've already seen showing the different chronic medical conditions that are associated with increased risk of severe disease. Once again, including lung disease, cardiovascular disease, immunocompromise, and diabetes, among others. And it's important to note, since we mentioned that the evidence base for RSV conditions or RSV risk factors that predispose to severe RSV in adults is more limited than that for influenza and for pneumococcal disease, for example. Clinicians might consider other chronic conditions that aren't explicitly listed here when deciding whether to recommend RSV vaccination to their patients. So once again, clinicians aren't limited to the conditions here. There are other conditions that can come into play when thinking through shared clinical decision-making about whether to recommend RSV vaccination. And additionally, we spoke about a few other risk factors that are associated with increased risk of severe RSV disease, which are residence in a long-term care facility, frailty, and advancing age. Regarding advancing age, since we're already talking about adults age 60 years and older, it may be somewhat confusing to think about what advanced age is within this population, and there's no specific cutoff. The incidence of RSV hospitalization we've seen increases with increasing age, even within this 60+ age group. And so clinicians can consider a patient's age in determining their overall risk of severe RSV disease and whether to recommend RSV vaccination. And next, regarding timing. Vaccination would optimally occur before the onset of the RSV vaccine, or sorry, the RSV season. We're already in December at this point, so the RSV season is off and running. RSV seasonality was disrupted during the COVID-19 pandemic, and RSV patterns are slowly returning to those that were happening pre-pandemic. So given that the RSV season has already begun, we're recommending that clinicians offer RSV vaccination throughout the season and continue to do so for adults who are eligible and who remain unvaccinated. RSV vaccination is currently recommended as a single dose only, and ongoing clinical trials and observational data may inform the need for additional doses in the future. One question that many clinicians are asking in the lead up to starting to administer RSV vaccines is whether RSV vaccine can be given at the same visit as influenza and other vaccines. Receiving multiple vaccines on the same day facilitates older adults staying up to date with recommended vaccinations, and co-administration is an important component of vaccination strategy. But limited data are available about co-administration of RSV vaccines with other vaccines. And to date, co-administration has only been studied with influenza vaccines. In general, co-administration of RSV and influenza vaccines met non-inferiority criteria for immunogenicity in trials, but RSV and influenza antibody titers were generally somewhat lower when both RSV and influenza vaccines were given on the same day compared with different days. However, that said, the clinical significance of that difference is unclear. There's no evidence to show that it reduces efficacy in preventing illness when they're given together. And additional studies are underway on co-administration of RSV vaccines with other adult vaccines. We do know that administering RSV vaccine with one or more other vaccines at the same visit could increase local or systemic adverse events like headache, muscle pain, or fatigue. So at this time, RSV vaccine can be co-administered with other adult vaccines, including influenza vaccine, COVID-19 vaccine, pneumococcal vaccine, and shingles vaccine. And if vaccines are not administered on the same day, there's also no minimum interval required between vaccines. When deciding whether to give RSV vaccine at the same visit with another vaccine, clinicians should consider a number of things: whether the patient is up to date with currently recommended vaccines, their likelihood of returning for other vaccine doses, their risk of acquiring vaccine-preventable disease, the vaccine reactogenicity profiles, and the patient's preferences. So in conclusion, there are new CDC recommended RSV prevention products that are available this season to protect the most vulnerable people from RSV disease. Clinicians caring for pregnant people, for infants, and for older adults should discuss RSV immunization and the options that are available. And this is a really exciting time in the RSV space because for the first time, we have the ability to prevent a considerable amount of morbidity from RSV in a large proportion of the population. And just a few acknowledgements for folks who contributed to putting this presentation together. And I'll go ahead and stop sharing.
Excellent. Thank you both so much. We do have a couple of questions I think we've got a few minutes to allow for that. I think maybe this first one would be to you, Commander Jones. Someone asked, why are American Indian, Alaskan Native infants at such high risk for RSV?
Sure. So it's not entirely known. It's thought to be related to socioeconomic factors, social determinants of health. Most of the research has been done in really specific sites, and it's not entirely clear if it applies to all American Indian and Alaska Native communities or just those that have been studied. I'm happy to provide a link to some recent research in the chat. But access to plumbing, crowded housing have been proposed as possible hypotheses.
Excellent, thank you. Yes, I'm a pediatrician myself, and I know historically we seem to see much higher rates of infections and hospitalizations in that population. We have quite a high tribal population here in North Dakota. We had another question. This is probably for both speakers. So given the potential serious adverse events for preterm birth and hypertension in pregnancy with the maternal vaccine and the potential serious neurologic complications in the adult vaccine, I think you addressed this a little bit. Are there plans for rapid cycle analysis for these signals in VSD or some other increased post-licensure monitoring beyond theirs? And then there was a qualifying question to that. What kind of studies, VSD retrospective analysis or more formal randomized controlled trials?
I guess I'll start off and then pass it off for the adult vaccine. So VSD is planning to perform analyses as quickly as possible in their population, looking at rates. So this would be retrospective, observational among those that do and do not receive the maternal RSV vaccine. I'm unaware of any additional randomized controlled trials that would, have sufficient numbers to look at this specifically for preterm birth and maternal vaccination.
And the answer is really the same for the adult population as well. So vaccine safety data link is going to be used. Rapid cycle analyses are taking place. And I'm also unaware of randomized controlled trials that would be conducted to look at this. I think it's really going to be these vaccine safety surveillance networks that are going to be looking into this.
Great, thank you both. Maybe we have time for one or two more here. Someone wrote in and asked if you had a pregnant daughter or a close relative who would be eligible timing wise for both maternal vaccine or the infant monoclonal antibody, which would you recommend and why?
So this is a question for me personally, if I understand, if I had a, so if, as someone who, I have 4 children, if I had regarding the, you know, it is a personal decision, but I think the first thing I'd have to look at is nirsevimab available in my area? Because if nirsevimab is not as available, then it's a pretty easy easy answer for me, is I'd strongly recommend the maternal vaccine, because that would be the only option available. So assuming that this the person's pregnant and they qualify, they're 32 to 36 weeks during September to January. I mean, it's a hard decision. There's not a lot of data on length of protection, but something that influences me a little bit is that the nirsevimab antibody has been engineered to have a longer half-life, and the antibody data that's been published on nirsevimab suggest it may have this longer protection. So particularly if the birth is going to take place kind of later in the season, you know, January, February, March, I think it although we don't know, nirsevimab may offer kind of protection going into the early part of the next season. Although the risk is going to be lower as the infant will be older at that time.
Makes sense. Thank you. I think maybe we'll just do one more if you guys are okay with that. We have a little time here. This 2 questions. What for the first presentation, the question was, although it states that the recommended timeline of Abrysvo admin to pregnant women is 32 to 36 weeks, do we have the option of giving after 36 weeks given the shortage of nirsevimab?
So I mean, it is a fully approved vaccine. So giving it after 36 weeks would be off-label use, you know, can be done. The reason we recommend 32 through 36 weeks is that it wasn't studied past 36 weeks. So a couple of things is we're not 100% sure about the efficacy. If you gave it at 37 weeks and the infant was born more than 14 days afterwards, it hopefully would be equally protective. But the later you give it, the less time you have to really build up the antibody level in the mother and then pass it through the placenta onto the infant. And then there is another product this season, might be a little difficult, but with nirsevimab available, the general recommendation would be if, say you hit September and you're already 37, 38, 39 weeks at that point, then I'd be strongly looking for nirsevimab in your area.
Okay, and then finally for the second presentation, if we have a patient willing to space out their RSV and influenza vaccine for optimal protection, what would be the recommended time?
So if the decision is made to separate those vaccines into 2 separate visits, there is no recommended interval that you would wait before you gave the second vaccine. But I would emphasize that co-administration of RSV vaccine and influenza vaccine at the same time is absolutely fine. And so when providers are thinking through this decision about whether to give the vaccines in the same visit or whether to space them, I spoke about some of the factors that you would want to consider. Do you think that this patient is actually going to come back before the end of the season to get the next vaccine? What do you think the risk is that the patient has of getting one of these respiratory pathogens before they return to get the next vaccine? So co-administration of RSV vaccine with other vaccines like influenza, COVID, pneumococcal is absolutely fine.
Excellent. Well, we would like to thank you both, Commander Jones and Dr. DeCuir, for being here and for these presentations, and to thank you for attending today's event. Final reminder for those seeking 1 credit of CE, please follow the link provided in the chat to take the post-test and evaluation. This must be completed for you to acquire credit. Thank you.
All right, thanks for having us.
Thank you so much.
Thank you.